Simone has worked for more than a decade in the education, treatment, and research of addictive behaviors. Simone is a lecturer at Auckland University of Technology in New Zealand, psychology, and an honorary senior research fellow with Turning Point Addiction Centre in Australia. A classification system to assess the effectiveness of problem gambling. An international research team has developed a system for classifying the components of problem gambling interventions. Applied to 46 randomized controlled trials, this tool identifies in problem gambling interventions 17 discrete behavior change techniques, 10 intervention characteristics, and 6 participant characteristics. Preliminary findings of an exploratory meta-analysis will also be presented that identify the content and study participant characteristics associated with better client outcomes. The classification system is a useful tool for identifying the potential content of interventions for problem gambling. This video has been professionally narrated from a presentation given by Simone Rodda on October 5, 2016. The research that I'm talking about today is a classification system that we developed to be able to organize the content of problem gambling treatment interventions. I'll give you a basic background to the project and some initial data. This report was literally submitted 3 days ago, so we're still thinking about this research and welcome your feedback. We convened an international team together with Dr. David Hodgins. We collaborated entirely online, and I'm hoping you will see the expertise that has come through this project. I'd like to thank the Gambling Research Exchange in Ontario for funding this project and the many research assistants who worked on this project. Now, we wanted to develop a complete online behavioral treatment program a couple of years ago. We went to the literature, and of course, the literature tells us cognitive behavioral therapy and motivational interviewing are both great treatments and that both of them did well. However, the literature did not tell us exactly what we should put in these programs. The literature did not give us a list of programs or a list of the components or strategies of each program. We had to look more broadly, and we found that in other health areas, these classification systems have been developed. The systems describe the content of each intervention. This led us to Professor Charles Abraham from the UK, who, with Susan Mushi, was the original developer of these classification systems. So as you see here, there isn't a classification system for problem gambling. The alcohol classification system, also referred to as a taxonomy, was published 2 years ago. It's quite a hot topic, but research only goes back to 2009, so it's relatively new. So we went into this to, first, develop a classification system that represents the content and characteristics of problem gambling interventions. Second, to determine the reliability of such a system, and then, third, to look a little bit about how these margins that we identified are represented within the gambling treatment literature. We developed the system based on all the randomized control trials that have been conducted for problem gambling. We looked at all the trials from a Cochrane review, a systematic review of self-help studies, as well as broader research and also some studies excluded from Cochrane. This slide shows where these studies were conducted. Most of them were recruited from the community. Some were from clinical services, colleges, and universities, but for the most part, there were therapists still with them. So this first step is about how we actually develop the taxonomy, and it's quite complex. So we're going to try and break it down as 5 steps. The way we developed the taxonomy was going to the gambling literature. So rather than looking at the literature more broadly and trying to apply that to the gambling literature, we looked at the high-performing studies in terms of sizes and the lower-performing studies, and we looked at the differences. So we went into it and said, okay, this study is doing cognitive therapy, this one's doing something else, feedback on assessments, and we had 2 things that were different. We then developed categories and labels and reapplied these. So the final product we refer to is the GIST-1, the Gambling Intervention System and Characterization. The GIST-1 contains 3 parts: categories of change techniques, categories of participant and study characteristics, and categories of intervention characteristics. The first part was about the change techniques. We had identified 17 change techniques: relapse prevention, cognitive correctional, behavioral substitutions, control. These were some of the most frequently endorsed terms. when we went back and looked at the relationships. Against these 17 terms, we also developed our descriptions of these items that had to be mutually inclusive of the gambling literature. It includes a whole range of different things people did in terms of relapse prevention and cognitive correction. This was when we went back to those 46 randomized controls, and we looked to see how many of the trials included these different change techniques. So the most frequent were this relapse prevention. Least frequent was communication trends and social comparison. Some of these are a little bit problematic in terms of gaps in the broader literature, such as self-monitoring and problem solving. So the second part was participant and study characteristics, of which we found 6 different participant characteristics. The first part was around how people were recruited: community setting clinic, integral setting, or university setting. We looked at remuneration, where the participants were paid for follow-up screening. You can see that the community and clinical settings were around the same in terms of the proportion of the studies using that type of technique. Around just under 20% of our interventions offered post-treatment incentives to complete follow-up. Screening was most often done by telephone, but assessment was most often done face-to-face, particularly in face-to-face therapist-delivered services. The most of the comparison groups in these 46 studies, or 88 interventions, was with a waitlist control group. The number 6 item of the participant study characteristics was eligibility criteria, of which we had 80 of these. The last 4 were around suicidal ideation, acute mental distress, current gambling treatment, and a collateral person. I think also I was a bit surprised that almost half of the gambling studies excluded people on the basis of suicidal ideation, and 63% of gambling studies excluded people on the basis of acute mental distress. This is a little bit curious given the high rates of comorbidity for problem gambling. 7% of therapist-delivered interventions are being delivered by registered or eligible for registration clinicians. The third part of the intervention classification system was around the intervention characteristics. This is how the intervention is delivered and who delivered it. This part is around qualifications, and we're seeking registered professionals, interns, student council volunteers. The next part is around where the solution changes were provided. Third, whether there was a treatment manual, whether there was a therapist to see that the intervention was delivered according to the treatment manual. Fourth was the therapist approach, and then the self-directed approach. So we've actually got about 10 of these, but I'll give you the percentages as we go. So you see here, 67% of studies involved a clinician that was registered. 68% of all studies reported that supervision was provided. Probably one of the most interesting things here is the number 3 item treatment manual integrity check. So just over half of gambling guideline controls were put into those that checked that the intervention was looked at as intended, because it's kind of important to know that sometimes clinicians don't do what they're asked to do, especially if it's a pragmatic guideline control. Now under therapist approach, the rollout when it was therapist-delivered intervention was 36%. So the other part of the intervention characteristics, in addition to qualifications training, is the duration of treatment, the type of context, individual versus group treatment, whether there was a goal set prior to treatment, if the treatment was therapist-delivered, then how they delivered it, and in the case of self-directed, how they delivered that. And so here are the percentages against each of those. You'll see that most of the guideline controls involved individual delivery. What you'll notice is that we coded the presence of each of these items in the studies. So some studies did both, and one study did individual and group. So that's why it adds up to a strange number. So in the studies, when it was a therapist involvement, 86% were face-to-face, but a smaller number by telephone or self-directed. The other thing we wanted to do was then to map the processes or the things that research is trying to change that will lead up to changes in gambling. This is something that was in the other classification systems, but unfortunately, we were not able to do that with the gambling literature, as it was generally not reported in more than half of the studies. So to give you an idea of what that means, looking at the process of change is a little bit like trying to identify what it is that is actually working in the treatment that makes the difference for the person. So thinking about it in terms of drugs, this is the thing that makes the difference, and all these other ingredients are the things that make it taste nice and palatable and making patients willing to take it. This raises questions about whether the intervention delivery is an active ingredient in this treatment or whether it's just a way of packaging it and helping it to get to people. We have started to look at this in terms of using better analysis. These are the consensus guidelines that talk about the reporting for reduction frequency and intensity of gambling and problems caused by gambling. Now, this is a really tricky slide. It's from a study where they had attempted to, across broader change, look at the active components of interventions for the different means. The aim was to address methods to change visual, automatic, or impulsive behaviors, and at least a bunch of theories of ways that you can adjust these theories. So this is kind of the way to do it. When you look closely at that, it actually doesn't look anything like the gambling interventions or what's happened. So this raises some other issues. The GIS-1 provides the first comprehensive list of potentially active ingredients for interventions. It provides a menu of options, putting in intervention developments. So myself and Stephanie McCures, who was one of the researchers on this, we both independently wrote protocol papers recently for some treatment studies, and we said to each other, how good was this checklist in terms of being able to make sure you included all of the things that should be in a trial in terms of guidelines, and makes it so easy. The GIS-1 also identifies gaps in underusage areas, and there are a number of change techniques, for example, that are used in broader healthcare in alcohol and smoking that aren't being used in problem gambling. It also identifies gaps in terms of reporting. One of the recommendations from Charles Abraham in the United Kingdom was that we consider some sort of narrative review. Identification and agreement on the range of specific crisis changes needed. So part of the issue is, how do we carve these up? How do you make it meaningful? Thank you. Any questions?
So when will you be providing this data to the Institute for Clinical Evaluative Sciences?
I receive no information or reports that drill down into this level of granularity around actually how treatment is provided.
One of the things I was thinking about was the way in which treatment is reported in Ontario and the extent to which any of this information is being collected or even documented, and so I wonder if some of you would speak to that.
Not that this challenges what you're saying, but the initial analysis suggests that some of these techniques are performing better than other techniques, and that's regardless of the therapeutic bond. But you also raise a really good point. It's only about 30% of these trials that are self-directed.
The idea of using this as a way to design a treatment, or even to take a treatment that you think you've already designed and drill down and figure out exactly what it is and which elements it contains, did you find it informative when you looked at the list at the end?
Not that this challenges what you're saying, but the initial analysis suggests that some of these techniques are performing better than other techniques, and that's regardless of the therapeutic bond. But you also raise a really good point. It's only about 30% of these trials that are self-directed.
Did you parse out the findings at all by country? I was interested if the US was being compared with Canada and Australia, because Canada and Australia seem like they might match. I'm just guessing, but they might map onto each other quite coherently. The US might be throwing things out of whack.
That's a great note. Most of the studies using university or college samples were in the US, while most of the studies using community or treatment samples were in Canada and Australia. However, we did not do analysis by country.